All right, thank you so much. So I have the pleasure of talking about the role of Ivus in calcified lesion intervention. Again, these are my disclosures. So I think a lot of the speakers earlier today morning, as well as the prior speaker, spoke about the fact that calcium is fairly frequent. So if you take a look at these 13 studies for drug-eluting stent approval, what they found was that the vast majority of them included patients that had moderate to severe calcification. So this was a exclusion criterion, but when an angiographic core lab actually looked at the angiograms, they found that moderate to severe calcium was present in about 30% of them. Now, if you go and look at an all-comers registry, you sort of see the same thematic aspect. And what you see is that greater than 30% of patients had moderate to severe calcification in this ADAPT-ES registry. Moreover, if you start to look at a higher risk population, the ACS population, again, you start to see that around 30% of patients have moderate to severe calcification. And if you have a STEMI, that number is even higher, closer to 38% or so. Now, as we know, as our population ages, you're going to start to see more and more calcification. And if you go to a higher risk subset, particularly those that have left main or 3VD, as in the Syntax trial, you go from 30% calcification all the way up to 50%. So again, calcification is going to be found in our everyday practice, and managing calcification is obviously going to be fairly important. Now, let's talk about stent expansion with calcified lesions. I think we all know practically that when there's a nodule of calcium or concentric calcium or even eccentric calcium, you know that stent expansion becomes highly problematic. The greater the arc of calcium, the harder it is to expand your stent, both at nominal pressures as well as higher pressures. So on the left is basically a study that shows stent expansion at 16 ATMs, and it basically shows sort of an inverse correlation. They also repeated this for 20 ATMs, and again, inverse correlation. And again, if you look at the arc of calcium, the greater the arc of calcium, the less your stent expansion, and the more likely you're going to need a calcium ablative strategy. Now, a trial that I want to point to is from Twente and the Dutch Pierce trial. And in this, patients with stable angina that had severe target lesion calcification, what they found was that there was a associated risk of obviously adverse outcomes. Specifically looking at TVF, at 2 years, there was nearly a doubling of the TVF when you had severe calcification. And then also 2-year stent thrombosis was also markedly higher. That was nearly 4 times higher. But the important part is that a lot of the calcification problems really come up front and then up to 1 year. So in this study, what they found was that the curves, if you had severe calcification versus no calcification as it pertained to TVF, the curve separated up to 2 months. And then when you did a landmark analysis, from 2 years up to a year, the curves continue to diverge. But after 1 year, the curves no longer diverge. So you basically pay a penalty within the peri-procedural part as well as up to a year. Now, this is a study by Samin Sharma. This was the MACE trial, and the MACE trial was a prospective multi-center observational clinical study that enrolled 350 subjects at 33 sites over the course of 2 years. And again, a core lab looked at lesion calcification, if it was none or mild, moderate, or severe, and then subsequently looked at various different endpoints. And what they found was while there was no difference in cardiac death, there was a marked increase in MACE rates, particularly as it pertains to severe calcification, nearly 24.2%. And this was really driven by MI and target vessel revascularization need. Now, this is an earlier study by Gary Mintz and colleagues, and again, what it basically showed is that we do a very poor job of detecting calcification with angiography alone compared to intravascular imaging. So when you looked at the degree of calcification, angiography alone was only able to pick it up 38% of the time, and there was correlation with angio and Ivus, the greater the degree of calcification. Now, our prior speaker spoke about OCT, and I think that OCT has a very profound role, particularly as it pertains to calcium modification. One of the areas where Ivus is lacking is that it does not really tell you the true thickness of a piece of calcium, and there are obviously implications of that. But Ivus, just like OCT, can basically identify calcification and then can tell you if you need to use a calcium modification therapy. And so if you know that based on certain parameters, you're going to need some sort of therapy that's not just an NC balloon. So one of the more commonly used scoring algorithms that uses Ivus and the need for an upfront atherectomy strategy was published by Zhang et al. From the Columbia group. And what they basically found was that you can look at 4 different parameters, and those 4 parameters would give you a point. And if you had 2 points or more, then you should go with an upfront atherectomy strategy. So the 4 criterion of this Ivus calcium score are: 1, if you had calcium arc greater than 270 degrees for 5 millimeters or more. The second was if you had any area, it didn't matter how long it was, just any area that had 360 degrees of calcium. The third was if you had a calcified nodule, and the fourth is an area that has calcium that's less than 3.5 millimeters. And if you had any of this, you would get a point, and if you didn't, you wouldn't get a point. And so if you had 2 or more, then an upfront atherectomy strategy was recommended. Now, these are 2 patients in that trial from where this score was derived. And you look at case 1, and if you look at each of the criterion, the only thing that the person had was 360 degrees of calcium. Their calcium score was 1, so you don't need to necessarily go up with an atherectomy strategy. And if you look at their pre-PCI versus post-PCI stent expansion, it was nearly 98%. Now compare that to the second case where you had a patient that had a calcium score of 3, so they had a length of calcium arc of 270 or greater, and they had about 8.9 millimeters of this. They also had a calcified nodule, and they had a vessel diameter of 2.9, so less than 3.5. And when they went with just a balloon-based strategy, the stent expansion was only 55%. So again, you can use this score to basically predict when you're going to need upfront atherectomy. Now, Ivus sizing. How are you going to size your stent and the balloons that you're going to use? So these are increasingly aggressive size measurements. So one of the easiest ways is to just go to the largest reference lumen, whether proximal or distal, and then sort of size your balloon to that. You can go mid-wall to mid-wall, and then ultimately you can go to media to media. And when you go media to media, you obviously don't want to have a perforation or a distal stentish dissection. So you do have to discount it a little bit. And there's some heterogeneity on what that discount is. Is it a quarter size down, or is it a half size down? Nevertheless, you should definitely size down. Now, I want to present one quick case that kind of highlights the importance of intravascular imaging when dealing with calcium, even severe calcification. So this is a 65-year-old patient with alpha-1 antitrypsin deficiency. As a complication of the deficiency, the patient developed cirrhosis requiring a liver transplant, also had pulmonary sequelae with a COPD requiring oxygenation at baseline, hypertension, hyperlipidemia, and was on hemodialysis. And he would have chest pain with dialysis sessions for the past 6 months. And then ultimately in his last session, he actually developed EKG changes with hypotension and he was found to have ST depressions in the inferior leads. The patient was referred to an outside hospital for a cath. And I'm going to try to play the films. And you can basically see this is the left system. You see that there's calcification in most of the left territory. You can see that there's left main calcification, there's nearly a subtotal of the LAD, and there's basically a lead pipe for the circumflex. Again, the changes were inferior, they weren't anterior. Again, more orthogonal projections here. You can see clear calcification all the way. There's also a link loop recorder, which you're seeing on the screen. Again, more pictures of the left. And for the interest of time, I'll just move to the right coronary. So the right coronary obviously has severe calcification. There's a subtotal there. And even before the artery fills with contrast, you can see that there's calcium on both sides, which means that there's severe calcification. And so this patient was referred to us for RCA PCI. By a quick show of hands, what do you think the diameter of that right coronary is ultimately going to be. Who here thinks it's going to be a 2.5 vessel? Raise your hand. Okay, 2.5. Okay, who thinks it's going to be a 3.0? Okay, who thinks it's going to be a 3.5? And who thinks it's going to be a 4.0? Okay. So what we did here was we went with the hockey stick guide. We were going to use upfront atherectomy. And so we atherectomized with a 1.25 burr. Ideally, I like to go with a 1.5, but unfortunately, it just wouldn't go. So 1.25 was used because of the subtotal nature. The 1.5 burr ultimately passed. Again, for the interest of time, I'm just going to get to what we need to do. But after some ballooning, we performed an Ivus run. And so this is the Ivus run back distally to proximal. Okay, so there are definitely stent fractures, calcium fractures that you can see. And you saw that the distal vessel was fairly large compared to what we thought it was going to be. And so when we looked on Ivus, this looks like it's at least going to be a 3.5 vessel. When we saw the diagnostic, it looked like that you'd be lucky to get a 2.5 stent in. But when you actually size it out using Ivus, you see that it's actually a 3.5 vessel or greater. So ultimately, we went with an IVL balloon, used it 1-to-1, and then subsequently stented, got 2 long 3.5 synergy megatrons, and then post-dilated to 4, and the final result is this. So again, we went from a vessel that looked like it was going to be a 2.5, maybe 3.0, and actually ended up with a 4.0 vessel. All right, so in conclusion, obviously coronary calcium is fairly ubiquitous. Greater than 30% of PCIs are going to have calcification. We know that outcomes are worse when calcifications are present. Angiography alone is suboptimal in detecting calcification, and Ivus can readily identify calcification, and it allows for figuring out if you need upfront calcification modification therapies, and B, ensures that we optimally expand our stents. Thank you so much.